If you are confused by all the talk about ever-changing incident rates of autism, you are not alone. This is likely one of the currently most confusing areas with regards to autism. The rates that are seen in the popular media and the internet have changed enormously over the last 20 to 25 years. A syndrome that in the 1970s had a rate of 4 per 10,000 to a current rate of around 1 in 150 to 1 in 100 seems very ominous. It is easy to see why lay people would talk about an epidemic of autism. It is important to understand, first of all, that almost the entire increase in incidence is in the mild range of autism. Even with the older, less sensitive diagnostic tools, it was generally possible to find virtually all the children with moderate to severe autistic symptoms. A very interesting finding is found in the formal research literature. In general, the larger and more formal the study, the lower the rate is. The smaller and less rigorous the study, the higher but also more variable are the rates. This is an area in which you must know the research directly to understand the outcomes. However, this being said, the current estimates for well-designed larger studies are still suggesting an increase in the incident rates. The appearance in the popular press is partly due to how the statistics are presented. Remember also that many years ago, the criteria were more conservative. This resulted in particular in not diagnosing many children who today would be diagnosed as having milder autistic symptoms. The older results typically came as two statistics: the core autism rate of 4 or 5 per 10,000, and a rate of 10 to 12 per 10,000 of children back then being termed to have autistic-like symptoms. By today's standards, most of the children in this autistic-like category would be diagnosed with autism. Assuming we use the current diagnostic criteria, with the older statistic, you get a rate of approximately 14 or 15 per 10,000, or around 1 in 700. This rate is in fact a close approximation to the finding in Europe, where typically the best epidemiological research occurs. The increase from 1 in 700 to 1 in 150 is still noticeable, but obviously not nearly as big as a change from 4 per 10,000 to 1 in 150. Most of the remainder of the increase in incidence can be accounted for by a number of observable factors. First is the quality of research associated with various estimates. Also, three of the more observable factors are better and more sensitive diagnostic tools, far greater public awareness of autism, and a much lower age at which a diagnosis can be confirmed. There is currently no conclusive evidence that any mystery causal agent is at play increasing the rates of autism. Modern biomedical research into autism started around 40 years ago. Even after all this time and hundreds of millions of dollars spent, we still do not have an empirically supported theory of the cause or causes of autism. Over this time period, however, there have been many theories presented. These range from the truly flaky to ones far more grounded in existing biomedical research. It has proven to be very difficult to obtain repeated empirical support for any specific theoretical mechanism. The need for repeated empirical support is crucial for all research, so not having it is a very big problem. The most commonly held hypothesis in the scientific community is that autism is likely caused by an interaction of a genetic predisposition and some form of early environmental insult. While there is some headway being made in identifying various genetic sites associated with autism, there is little progress in identifying potential pre- or postnatal environmental insults that may also be involved. How these two types of factors work together, resulting in autism, is still unknown. Genetic factors are the most significant factors associated with autism spectrum disorders. However, the genetic effect is complex. We will discuss this more in the next slide. The issue of whether early childhood immunizations are a contributing cause to the current rise in autism has received enormous press coverage. The fact that following a review and investigation by leading medical authorities resulted in the lead author eventually losing his license to practice in Great Britain, and that all the other authors of the original article that sparked this debate retracted their support for the paper received far less coverage. Only those with a bent for conspiracy theories now carry the torch for such a position. Not having children immunized is a far greater public health risk. In the developed world, we have not seen the effects of many of the terrible diseases now controlled by immunization programs. The death and disability rates for all the diseases now covered by early immunization programs is actually extraordinarily high, should the disease again become epidemic. Risk factors for autism, such as advanced paternal age or gestational diabetes, have been identified. Teratogens or environmental agents that cause birth defects are associated with autism but are relatively rare. Fragile X and tuberculous sclerosis complex are two other conditions with genetic loadings associated with autism. The wide range of known but oftentimes rare risk factors tend to support the position that autism is a complex syndrome, as none of the specific risk factors account for a very high percentage of people affected with autism. While the changes in incidence rates are oftentimes confusing, the role of genetics in autism is just as confusing. There has been extensive research on the genetics of autism. While at some level there has been general agreement that genetics likely plays a role in autism, obtaining agreement on what this is has proven to be very challenging. Currently, there are over 25 genetic sites across several chromosomes that have been identified as related to autism in at least one study. It is expected that as more research is done that this number will grow. This broad genetic influence, in a way, is consistent with the wide variations in autistic symptom patterns and intensity. If, for instance, only a single genetic site was associated with autism, it would likely be very difficult to explain all the symptomatic variations we observe in autism. Possibly, future research will determine that any number of the known genetic sites may separate into a small range of common genetic patterns that more likely are related to specific symptom patterns, thus demonstrating genetic subtypes of autism. It is important to understand, however, that the genetic research at this point is correlational in its design, not causal. In other words, the research is identifying genetic site variations that go with or are associated with a diagnosis of autism, but do not in fact determine that the genetic variation causes autism. This is often a distinction that is very often difficult to grasp without training in research methodology and is not helped by the often misleading popular press phrasing of their simple summary of what are generally highly complex and specialized research studies. One thing that does appear fairly clear from the genetic research is that most of the cases of autism are not due to inherited traits from the parents. This is known by the fact that while the children will show genetic variations associated with autism, such genetic variations are typically not found in the parent's genome. This is very similar to Down syndrome, in which the child will have a third chromosome 21, but his or her parents do not. On the other hand, Fragile X is known to be transmitted across generations. Thus, the focus on genetic counseling for affected families or individuals with Fragile X. There are no genetic tests available for autism at this time. Genetic testing may be suggested by a physician with regards to disorders that have higher probabilities of having a child diagnosed with autism, such as Fragile X, but in this case, the genetic testing is for the testable condition, i.e. Fragile X, not directly for autism. Of course, it is also possible that a child with autism may also have a separate genetic condition for which the geneticist may wish to test. Again, this testing is for the separate genetic condition, not for autism per se. There is a strong relationship between autism and intellectual disability. Historically, when the rate of autism was lower, the percentage of individuals with autism who also had an intellectual disability was often determined to be around 80%. The change in incidence rates over the last 20 years make it difficult to clearly establish what the rate currently is. It can be assumed that most new cases of autism are in the mild range, thus generally lowering the percentage of people also diagnosed with an intellectual disability. Regardless of the exact percentage, it is still the case that many individuals with autism will also have an intellectual disability as well. This will mean that such individuals actually have a dual diagnosis of autism and intellectual disability. Having a dual diagnosis means needing to pay attention to how the two disorders may interact with each other. People with autism will show problems in social and communication skills. Children and adults with an intellectual disability will typically show delays across all areas of functioning, including social and language skills. Having both means either the person, while showing global delays in all areas, will be showing particularly severe delays in social and communication skills beyond that which would be expected given their other skill sets. Or the person may show relatively similar levels of delay in all areas, but will show qualitatively odd delays or difficulties in social and communication skills. These descriptions suggest that having autism and an intellectual disability may appear as an additive effect, that is, a greater than expected area of impairment in social or communication skills, or more as an abnormality in social or communication skills. Often, however, the effect is more like an exponential increase in difficulty and complexity. The reality is many people with both autism and an intellectual disability require large and extensive amounts of service supports. Fragile X is caused by too many repeats of genetic material on the X chromosome, making one tail of the X chromosome appear fragile when doing genetic investigations. Fragile X syndrome was first documented by Martin and Bell in 1943. The break, just above the tip of the X chromosome's long arm, which is the fragile site, was first demonstrated microscopically in 1969 by Lubbs, but was not confirmed until 1977 with the discovery that a specific medium for culturing the test material was required to show the fragile site. Fragile X is the most common form of inherited mental impairment. In comparison to the discussion of the genetics of autism, which is mostly not inherited, that is, the genetic variation is not found in the parent's genome, for Fragile X, the parent is often a carrier of the Fragile X site. However, new cases can arise with no family history of Fragile X. While the statement is frequently phrased, Fragile X is the most common known single gene cause of autism or autistic-like behaviors, the actual causal mechanism is not known, and only a small percentage of people with autism, about 2 to 6%, have Fragile X. Approximately a third of all children diagnosed with Fragile X will also have some degree of autism. To reconcile these statistics means that autism, 1 in 150, is far more common than Fragile X, which is about 1 in 3,000. Please be aware that both of these rate estimates are likely to change over time. However, the scope of the difference will likely remain very large. Notice that a more severe case of Fragile X will potentially produce a triple diagnosis of Fragile X, autism, and an intellectual disability. As each of the diagnoses have separate characteristics, the complexity of understanding how they will impact the person together is very challenging. Besides Fragile X and intellectual disability, there are a few other conditions that are commonly associated with autism. Seizure disorders are very common in children with autism, becoming more common if the child also has a moderate to severe intellectual disability. While a seizure disorder can occur at any time, it is much more likely to start either in early childhood or in early adolescence. Medications are the treatment of choice for seizure disorders. Tuberous sclerosis complex is a rare genetic disease that causes benign tumors to grow in the brain and on other vital organs such as the kidneys, heart, eyes, lungs, and skin. Its exact relationship to autism is unknown. However, given the high frequency of an autism diagnosis for individuals with TSC, there's ongoing genetic research looking at what may be common genetic factors for both disorders. On a completely different note, it is also important to assess many children with autism to verify their hearing and vision. Given particularly young children's difficulty with language development, as well as the presentation of odd apparent visual acuity problems, for instance not attending to obvious visual cues in the environment, it is important to ensure that such problems are not symptoms of actual hearing or vision impairments. Over the last 40 years, there have been several case studies reporting the mistaking of what turned out to be hearing or vision impairments as being autism. It is of course possible that an individual with autism also has a hearing or vision impairment. High-functioning autism is a descriptive term, not a specific diagnostic term. In general terms, high-functioning autism is used to mean the person with autism does not also have an intellectual disability. This definition thus means all children and adults with an IQ over 70 would be classified as having high-functioning autism. In fact, this is the group who represents what autism appears to be as a unique diagnosis on its own, without the confounds of having other diagnoses such as an intellectual disability. For research purposes, high-functioning autism is at times defined more restrictively, for instance to mean having an IQ score within the range of 85 to 115, in order to be comparable to one or more comparison groups having equal IQs. When talking about an IQ score in these terms, what is meant is a global IQ score that is consistent with a set of subtests used to get the global score. It is not uncommon for individuals with high-functioning autism to have such wide variation in their subtest scores that it is not actually appropriate to use a global IQ score. Many individuals with this wide scatter in their scores, regardless of how high the scores are, often have significant problems functioning in everyday life. It is quite obvious that people with high-functioning autism will in general function better than individuals with autism and an intellectual disability. However, it does not by itself actually make a strong statement regarding the person's ability to adaptively function in everyday life to the standards of their chronological age peers. In fact, oftentimes people with high-functioning autism have a very difficult time meeting such expectations. Part of the reason for this is that defining high-functioning autism this way does not actually address just how severe the symptoms of autism actually are for the individual, or account for the many other forms of cognitive impairments they may demonstrate. When discussing the severity of autism, two quite different definitions are oftentimes used, which can lead to confusion. The most common definition of severe autism is when people are talking about an individual who has both autism and an intellectual disability. Oftentimes, the intellectual disability has not been fully measured, which leads to more confusion. This can be for a variety of reasons, such as the person has great difficulty engaging in such assessments. Parents may or may not understand that their child may have more than one diagnosis. Funding issues. For instance, having one serious diagnosis, i.e. autism, brings in the funding, while having two diagnoses brings in no more funding and simply costs money to do the assessment. The general perspective that more assessment work would not be informative. Regardless of the rationale for not completing a full assessment, it is in general the case that the less we know about a person's diagnostic profile, the more likely we are to make less optimal planning decisions to assist the person and his or her family. Much of the severity in this situation is due to the person having two significant and highly interactive disabilities at the same time. The second definition of severe autism relates directly to the actual severity of the symptoms of autism, as well as at times the total number of symptoms the person demonstrates. This is done independently of the person's intellectual ability, and for the most part is usually only meaningful for children and adults with IQ scores of approximately 60 or above. This definition is important as it clearly identifies that while a person may in fact even be above average in intellectual ability, that they are severely impaired due to their autistic symptoms. These two definitions represent quite different groups of people within the world of autism. Virtually any form of service delivery, from parent support through to vocational options, will be very different for these two groups of people. It is thus very important to understand which definition of severe is being used. There has been and continues to be broad interest in the sensory development of children with autism. Unfortunately, the models of neurological processes that have been at times suggested as explanations for autism lack hard evidence supporting that the theories are accurate. Data on sensory-based interventions, even after more than 50 years of work, is minimal, and the findings are generally that there is no effect or very little effect. As well, when effects are found, such effects are oftentimes not easily related back to the theoretical model of the sensory process in the first place. This makes it very difficult to interpret what the change means, particularly with reference to supporting the original theory. While research on the sensory systems of children, particularly with reference to specific known neurological pathways or processes, will continue, it is not clear that any sensory-based interventions will demonstrate significant effects until the basic research can confirm primary pathways and/or processes that are disrupted, thus pinpointing areas for targeted treatment. As a Koskin et al. Quote indicates, actual demonstrable connections between observed sensory abnormalities and neurological structure is very new. This clearly brings into question what basis people have for the development and design of sensory interventions, given that such interventions typically make strong claims of being based on neurological findings and/or theory. There is also a very critical distinction to be made as well between the cause and effect relationship that such research may uncover. For instance, does autism cause the sensory abnormalities? Do the sensory abnormalities cause autism? Or is there some other agent responsible for both? Which of these questions is correct will change the focus of interventions. Without hard supporting evidence, sensory-based interventions tend not to have a clear focus, which is likely one of the strongest reasons for the lack of empirical support for such interventions. There is huge confusion how the term sensory integration is used. Sensory integration as a treatment was developed by Anna Jean Ayres in the 1960s and predates any neuroimaging technology by 20 years. Such sensory integration techniques as brushing, weighted vests, snoozing rooms, etc. are typically provided by occupational therapists. Over time, independent research into a theory has led to the theory being discredited. On the other hand, the descriptive terms sensory integration, sensory neural pathway, sensory integrative pathway, etc., as used by neurologists and neuroscientists is meant to describe various pathways, neural networks, or interconnections between known sensory processing areas of the brain and other brain areas. Work to date in which a specific treatment is designed to affect a known sensory pathway in individuals with autism, in which that pathway is measured pre, during, and post-treatment, has not, to my knowledge, occurred. Part of the reason for this is the still exploratory level of this form of neurological research and the still relatively gross level of the measurement and limited flexibility of our current neuroimaging technology. Our neuroimaging technology, while far superior to what we had even 10 years ago, does not typically image in real time with a live intact human at the cellular level across neural pathways. That is, we don't actually see the brain operate directly. What we see in functional imaging is mathematical algorithms, averages of proxies to cellular activity, for instance changes in oxygen or blood flow, that is interpreted as representing the core area where neural processes occur. Statistical averages are gathered either across multiple trials for one person or a single trial across multiple people. Brain scans that are generally seen are thus pictorial representations of broad mathematical averages. The unfortunate overlap between the two terms sensory integration, Ayres theory and procedures, and sensory integration as used by neuroscientists cause significant confusion for many. Sensory integration therapy is widely used with little empirical support for its effectiveness. Sensory integration research is still working on defining and measuring consistent sensory pathway disruptions in individuals with autism and is far from providing data consistent enough to develop treatment options that can be quantitatively measured at the level of the individual person's neurology. Telling the difference between expected child development and treatment effects is a highly complex affair. By outcomes, it is meant the measurable change in the child between time 1 and time 2. Even for children with severe and complex disabilities, if time 1 and time 2 are reasonably far apart from one another, you will be able to measure a positive change in at least some aspect of what the child is able to do. This is without any direct intervention. It is a function of their development and experience. Claiming such changes as being due to treatment is completely inappropriate and invalid. Treatment effects are defined as those effects that are found in different comparative research studies to continually occur when a particular treatment is provided, and such effects are significantly greater than the outcomes that would have occurred due to the child's expected development and experience. This is in fact very difficult to do. With regards to autism, there has been and continues to be a complex web of information regarding apparent treatment options. This ranges from empirically supported treatments through to marketing unsubstantiated pseudo-treatments. It is a complete buyer beware market. It is far easier, faster, and less costly to market a pseudo-treatment than it is to do the necessary multiple controlled research studies to verify a treatment effect, which, as with applied behavior analysis, has taken over 20 years. Even with established treatments, marketing can still have unwanted effects. While applied behavior analysis, or ABA, is viewed as the only treatment with significant amounts of empirically supported research, it is in the midst of a marketing war in which many agencies are rebranding ABA into what appears to be a proprietary or unique treatment. While this marketing of ABA is actually about a treatment that works, the vast majority of marketing of treatments for autism are for activities that have no empirical support and rely on vague terms that allow them to typically claim expected child development outcomes to be the result of their treatment. Beware that just because someone says that what they are selling has studies published in professional journals does not mean that such studies meet the criteria for providing empirical support for that treatment. Professional journals publish a wide variety of articles, only a small percentage of which are empirical research studies. Case studies and anecdotal reports, no matter how elaborately done, do not meet criteria for empirical research. To gain empirical research support for treatment is about far more than just collecting data. Solid research methodologies are essential. What is hard for most parents and funding agencies to hear is that even the most effective treatment can only provide you with a probability that it will be successful, not a guarantee. The fact that all treatments, whether in medicine, psychology, or other disciplines, can only make a statement of probability needs to be remembered. This is why professional licensing standards explicitly require such licensed professionals to make statements about the probability of success rather than giving guarantees. Non-professional marketers, however, are under no such obligation. It is the proverbial, if it sounds too good to be true, it probably is. Enormous pressure can be put on groups charged with doing a systematic review of the literature to determine what, if any, treatment is supported by the empirical research. The easier the criteria for inclusion into the review, the more likely an activity will be found to be therapeutically effective. On the other hand, putting highly rigid standards that most studies cannot meet may result in a study that says nothing works. Define what the problem is for who. It is essential that a review clearly defines what the problem is that is being addressed. For instance, general overall increase in development, ability to independently meet educational standards, increased use of language, etc. It is also important to identify who the study is about. The review could, for instance, focus on young children with autism, only children with autism but no intellectual disability, adults with autism, or other groups of interest. These decisions will define what research a review will look at. Review the empirical research literature. Some studies only focus on what is called peer-reviewed articles, while other studies will use material from a range of sources, such as book chapters, dissertations, monographs, etc. Peer-reviewed articles will give the generally highest quality material, while broader searches will increase the sheer amount of material to review. Compare and contrast the results in a systematic, data-based manner. This is the most complex and time-consuming aspect of finding out what works. All research to be reviewed must be put through the same analysis process and generate the same sort of data so that comparisons can be made across studies. It is not uncommon to have only a small percentage, e.g. 5 or 10%, of all the original articles gathered for the review to make it into the final review, many times due to problems with meeting the criteria for having used an acceptable research methodology. The answer you get from systematic reviews is applied behavior analysis. This is the answer for two reasons. The first is that there are repeated studies showing that ABA is more effective than doing nothing or doing what is typically provided as treatment services, for instance, special education or multidisciplinary teams. Secondly, attempts at developing alternative interventions have been unsuccessful to date because either there is sufficient research to evaluate them and the outcomes suggest no therapeutic impact, the research is not of good enough quality to include in a review, or there is simply not yet enough research, regardless of quality, to include in a systematic review. It is always on the researcher studying possible new treatment to conduct the necessary high-quality research necessary to satisfy typical scientific standards. The onus is on all professionals to be thoroughly trained and current in reading the available empirical literature regarding what treatments are actually effective. There seems to be an odd disconnect between a system's demand for highly trained professionals to do diagnostic work, and yet at times an almost complete disregard for the level of expertise of service providers. For example, a jurisdiction will demand that only a psychologist or physician can make a diagnosis of autism. Yet a recommended service provider list may contain a wide variety of service providers who, for instance, may simply be grandfathered onto the list regardless of changing professional levels of training needed to provide effective services. Rationales for not developing and maintaining high service provider qualification levels usually revolve around the notion that since we don't have enough qualified service providers, we have to do something, therefore we need to have low standards to get the quantity of service providers we need. This, of course, is not done with regards to diagnosis. Imagine this. We don't have enough qualified psychologists or physicians, so we will let anyone interested in doing diagnostic work do the work. Where does this happen? Nowhere. On the other hand, how about this? We don't have enough qualified behavioral service providers, so we will open the bidding to anyone interested in doing the work. Where does this happen? In many places. If a list of recommended service providers is available, the standards and verification process needs to be understood. Certainly in the US and Canada, there is a growing number of professionals obtaining their board certification in behavior analysis. Other than psychologists who are specializing in behavioral or cognitive behavioral psychology, it makes little sense to hire anyone else. It obviously makes little sense to compare, say, one treatment that is done properly with another treatment that was done improperly. However, with regards to ABA services, the history is actually far more frequently been to evaluate it without regards to whether it was provided by qualified service providers and or even done properly. This occurs frequently at a local level where no qualified service providers exist, but an individual or agency steps in and says they could do it, usually with no questions asked. That it typically does not go well should not surprise anyone. Obviously, lobbying to develop standards of expertise and practice are essential. Funding agencies can also work effectively to raise standards by providing differential funding to more qualified service providers. If you're going to work with individuals who have autism, whether children or adults, you need to understand what the core issues are regarding the diagnosis, and that these issues are more unique to autism than to other diagnoses. It is simply a small part of coming to know who you're working with. No one should be defined simply by his or her diagnosis. Everyone is far more than that. It is an unfortunate reality for many individuals with autism that they will often have to deal with the effects of two or more diagnoses, for instance autism and attention deficit disorder, each with its own potential form of impairment. How such multiple diagnoses interact is critical to understand as part of any planning process to provide treatment and or services to the individual child or adult. There has been an increasing rate of autism documented since the 1990s. No specific causal factors being identified for this increase. Much, if not all, of this increase could be due to having far better diagnostic methods, vastly increased awareness of autism, and the ability to make diagnoses at much earlier ages. For any proposed treatment, it is very challenging to conduct sufficient high-quality comparative research studies to demonstrate that the treatment is truly effective. In reality, this may take 10 to 25 years of research to fully demonstrate. The world of autism is full of pseudo-treatments being marketed which have no evidence that they are effective. ABA is the only comprehensive treatment option for autism at this time. It is interesting to note that while the medical research is identifying more and more genetic involvement regarding autism, that it is a behavioral intervention that is the most effective. What is going to be better understood is that changes in behavior can indeed change gene expression. In the last part of this presentation, we'll cover a range of associated issues regarding autism, such as transitions, cognitive and mental health issues, and the role of medications.